Better health, better care, lower cost. Everyone's talking about healthcare, but how much do you know? Better Health is brought to you in part by Sleep Better Northwest. Explore the healthcare system and listen to experts with your host, Sue Lonnie Madsen, here on Better Health.
Welcome to Better Health, and my guest today is Dr. Robert Bray from Hospice of Spokane. Welcome.
Thank you.
I should have asked if I should call you Dr. Bray or call you Bob.
Either way.
Either way. So Dr. Bray, I've really wanted to have someone on to talk about hospice care for a while. I've had friends who've made use of that care, and recently we've all heard Barbara Bush and her family mention that she had chosen comfort care in her final days, and maybe you could help us understand what that means and what a broad range that term covers.
Sure. I think the key thing about Barbara Bush's experience is there's a lot of that's private that we don't know about, right. And so they're fairly limited in what they told folks. But she clearly looked at a very limited prognosis that she was given, and she made a choice between trying to do things that were life extending and trying to focus instead on what's going to make me comfortable for the time that I have remaining. And that really is what comfort care is all about, is using that as the litmus test of what kind of interventions do I want to have. The thing that's unusual about the reporting for that is we're understanding that she made a decision to go to comfort care and then she died within a few days. And that's not a typical thing, so there may be much more behind those choices that might explain that, and I certainly haven't seen any reports that would help me to understand exactly what was going on. But I think it's really all about the litmus test of how am I going to make decisions about the kinds of interventions I want and don't want. And so some people may consider one treatment to be a comfort treatment, others might see that differently, but that's what the dialogue is all about, is let's talk about the time you have left, what's important to you, and let's use the litmus test of, is this going to make me feel better if I do this, or if I withhold that? So that's really what that's all about.
I know a lot of people have read or listened to him when he came to Spokane, Dr. Atul Gawande, talk about these kinds of decisions being about what does quality of life mean to each individual, and to one it might mean strawberry ice cream and watching football, and to somebody else it might mean being able to have a really lucid debate in spite of whatever that might mean giving up in terms of pain amelioration. And
right.
Just it's very individual. I think that kind of palliative care, really focusing on the patient, is what people need to understand.
Yeah.
So at Hospice of Spokane is one of a number of hospice programs that are available. In doing a little bit of research, I found that since the beginning of the hospice as kind of as a specialty or as a focus in 1974, the number of programs has grown from one in 1974 to 5,800 in the U.S. And as of 2013. I imagine there may be more now. When did Hospice of Spokane get started?
So we just recently had our 40th anniversary. So we were one of the first dozen or so programs that were Medicare-approved hospice programs in the country. So we're quite proud of that.
I think that's something that people need to know as well. It is a kind of care that that Medicare will cover in certain circumstances. And what are some of those circumstances?
So what Medicare, and I think Medicare has really gotten a lot of things right with hospice care. What Medicare wants to do basically is to say if someone has a prognosis of less than 6 months, and it doesn't really matter what the terminal condition is that's affecting that prognosis, then they should be eligible to have their Medicare benefit transfer to the hospice benefit. And what that basically means at that point is hospice then acts as the payor for the services that they're going to get for the period of time that they're on hospice services. So hospice provides the medications for the symptom control. It provides durable medical equipment that people might need to be brought into the home. And it is providing these nursing services, social work services, chaplain services, bereavement services, health aid services, all to where the patient calls home. So it may be their home, it may be a facility, it could be a hospice facility such as our hospice houses. So basically there's a basket of services that are being expected to be delivered by Medicare-approved hospices, and that's what that looks like.
Okay. And one of the key things you said there is that can be in someone's own home, or perhaps in their adult child's home, wherever they're being cared for with family, or in the hospice house, or would it also cover services if they were in a skilled nursing facility?
Yes, they can certainly be on hospice in a skilled nursing facility as long as Medicare is not paying for the skilled nursing services there. It can be a little bit confusing to folks, but for some folks who are in the hospital for a period of time, excuse me, and then go on to a skilled nursing home, sometimes they are going to be under Medicare reimbursed services for the first 90 days or so in that, or up to 90 days in that nursing home. If that's the case, Medicare pays for that, and hospice can come in later if that's the case.
So now we're getting into the weeds of how complicated our billing system is in this country. So there is a system in place. Somebody can figure that out.
Correct.
Okay, we'll remember that part. One of the things that I think people sometimes assume about hospice is it's just about someone who has a diagnosis of cancer. But you've mentioned that it's a much broader range of diagnoses. What are some of the more common ones that you see?
So after cancer, which is, there's all kinds of different cancers, that still is a little less than, between 35 and 40% of patients, describes patients anyway, that come to hospice services. But another large one would be dementia. So for folks in the last 6 months of a dementia problem, they're eligible for hospice services. But it's also end-stage heart disease, end-stage liver disease, end-stage lung disease, ALS, AIDS, stroke. There's all kinds of different conditions that are going to contribute to someone's prognosis of less than 6 months, and any of those diagnoses could qualify them.
So when U.S. doctors have gotten really much better at diagnoses, but prognosis is still has a great deal of art to it.
Yes.
We'll talk about people like my neighbor whose father got better and had to leave hospice care and then kind of come back to it later. How is that something that you see, and is there a problem with doing that?
It's not a problem doing that, and my father had the same experience on hospice services, and it's not uncommon. If somebody has a cancer diagnosis that brings them to hospice, usually the trajectory of their illness is more predictable. Seldom does anyone with metastatic cancer improve to the point where they would no longer qualify for hospice. So that's a seldom seen situation. But there are folks that come in and they've gone through a deterioration regarding their end-stage heart disease, say, or end-stage lung disease. They come on to hospice services. They get wonderful case-managing nurses and social workers to come into their home to make sure that their medications are what the doctors want, that they're compliant with that, and they deal with the issues related to that. Most of these medications are being delivered directly to their home as opposed to having to go out and get them. So it's not uncommon that sometimes folks, and we didn't necessarily predict it, but some folks can stabilize or at least improve some. They can improve to the point where they no longer meet the guidelines. And when that happens, Medicare, certainly if that's the payer, Medicare would say, well, they have to come off hospice services because they don't meet the guidelines. We call that graduation. And we try very hard to explain that this is the reason why. And if they decline in the future, which all of us will at some point, they certainly could come back on to services. One of the things that Medicare got right with all this is that they said that you have to have a prognosis of less than 6 months, but recognizing that prognostication is not a real accurate science, if they if their service goes longer, but they continue to qualify for services, they're continuing with a trajectory of their illness that is leading toward death, they can remain on hospice services. And even if they were on for 6 months or more, stabilized and came off hospice services, when they requalify, they can come back on, and there's no penalty to the patient at all for that kind of experience.
Okay, so they do look at not just it's a timeline, but they also look at how is the patient doing, and is this continuing to slide down, or is this stable?
Exactly.
Okay, well, that's good to know, because I was afraid it was just like you hit 6 months.
No.
You're out of here.
No arbitrary endpoint like that.
Okay. So how do you get admitted into hospice services? Is this something that you have to ask your physician about, or physicians bring it up, or what's the most common scenario there?
There's all kinds of different ways that people come to hospice services, and I think an important thing is anyone can make a referral to hospice services. So the referral means somebody out there thinks they might qualify for hospice services, and they may be interested in receiving them. So what happens typically then is they're evaluated by that hospice program, and simultaneously they're asking them who is the doctor, and they contact the doctor for information so that we can help determine and also ask the opinion of their physician. What do they think about their prognosis? Ultimately, the medical director of the hospice has to be able to make the case for a 6-month or less prognosis in a narrative format to Medicare. And that is going to be supported by not only our personal evaluation of the patient, but by the records that we've received and that we've requested from their treating physicians to try to put that all together. If someone's treating physician doesn't believe they have a less than 6-month prognosis, then we're obviously going to have more dialogue about that and discussion before we would move forward with any kind of an offer of services.
Or get a third physician for a tiebreaker?
Well, or at least 2 physicians talking more about it. Yeah.
Yeah. Okay.
Yeah.
Well, let's take a little break here, and we'll come back and talk a little bit more about the service available. Thank you.
See you tomorrow night, and thanks again for taking care of the painting.
I got this.
Bye.
Weekends are made for painting. Let the experts at Rada Paint take care of you.
Hi. This looks amazing.
Rada Paint, over 80 years of quality, tradition, and trust. Find it in every can.
To find the right home for you, you'll work with your realtor to compare the properties you're interested in, analyze the market, and figure out a reasonable offer price. And now, here you are, ready to make an offer. Yay, you! Here's how it works. First, you'll complete an offer sheet which your realtor will then present to the owner. Sometimes, a nice note to the owner can help your offer stand out. Butter them up. Tell them how much you love their garden, that it reminds you of gardening with your grandmother as a child. Do not mention you're gonna bulldoze it and put in a pool. The owner may accept the offer, reject it, or counter. It's important to be in close contact with your realtor during the negotiation process so any changes can be reviewed. Your realtor is like your consigliere, and that makes you the Don. Once your offer is finally accepted, there are usually some contingencies that must be met in order to keep the contract alive. Inspections are totally common in real estate transactions. They include termite checks, surveys to determine boundaries, appraisals to determine value for lenders, title reviews, and structural inspections. This stuff is mind-numbingly fascinating. But you know what's even more fascinating? Actually getting your new house.
To help you be safe, Washington state law requires you to call 811 2 full business days before you plan, for example, to dig, drill, plow, pull from, or pound anything into the ground. Be prepared to provide the operator with the correct address, cross street, and a description of your work. You must mark the dig area with white paint. The operator will inform you of the utilities notified of your impending excavation. Wait for all their marks. Be safe and dig with care.
Okay, and we're back. We were talking just a little bit about the history of hospice care, and the woman who really pushed this in the modern sense was Dame Cicely Saunders of Great Britain. And my notes say she's a physician, but Dr. Bray, you're telling me that she was also a nurse and a social worker.
My recollection is that she started off as a nurse, had an injury that kept her from doing that. She went into social work, and then from there figured in order to make the changes she was interested in, she needed to do that from a physician perspective, and then became a doctor. I'm pretty sure that's the story.
Well, it pretty well captures what hospice care is, because it includes all three of those
Yes.
professions at a very high level. And that was in 1948 when she started her work. One of the first times this came up in the U.S. was 1960s. Florence Ward invited Saunders to come and teach at Yale, and everything started kind of rolling from there. That's where, so the start was 1974, the modern hospice movement here.
Yeah.
One of the other things we talked a little bit about Medicare and getting admitted to hospice, but let's talk a little bit about hospice at home and what that might look like for people. What kind of support? So if I have a friend who had a nice spare suite, like a second master suite, and her father is at home, how would she be interacting maybe with hospice services?
So the hospice would want to understand who are the important caregivers and helpers for the patient, identify who those folks are, and make sure that they're part of the team that's helping to care for them. The case managing nurse would make visits to the home, and the purpose of those visits is primarily to make sure that the symptoms that are bothersome are being addressed. They're being addressed with effective medications and strategies, and to not only make sure that today that those needs are being met, but anticipate over the next week or so, between visits, what am I going to anticipate the needs might be, and what do we need to have in place before then? So the nurse is going to visit on average probably once a week. There are Medicare regulations that say it has to be at least every 2 weeks, but that would be relatively infrequent for a hospice patient. Mm-hmm. So then they're going to have a case managing social worker who will do the same thing, come into the home and address what need to be addressed from a social work perspective, whether that's emotional support, whether it's support to help them access services, other services beyond hospice.
I want to stop right there on social worker. I think a lot of people think of social worker as somebody who is not necessarily part of the healthcare team. Mm-hmm. So in this setting, my understanding is that what the social worker is really looking at the social and family setting outside of the health needs of the patient. Is that kind of roughly how that works?
Well, yes, but I would change that a little bit by saying that those things are part of the health team and part of the health approach. It's mandated by Medicare that be part of the team for each patient. So a lot of times the social workers find themselves in a situation where they're counselors in a sense. Mm-hmm. What is it helping people to determine what is important for me right now? What are the things that I want to get accomplished in the time that I have remaining? And so the nurses are probably going to focus more on the physical symptoms of the patient and the medical treatment. The social workers are going to focus more on the emotional and the spiritual aspects of their care and their needs. Okay. And they're going to do that in a team approach. They're talking to each other about these things. They're helping each other with with approaches and strategies, and those team members then get together on at least once every 2 week standpoint in a larger interdisciplinary team meeting where the leadership is present of the hospice, including myself, and we would be talking about their progress, what their needs are, looking at if those needs are adequately being met or if we need to change things in order to meet them better. So So that's kind of how that would look for most patients in a home setting.
Okay, and that includes some of the support, like bringing in pieces of equipment that might be necessary for a family to be able to
Right.
to manage them.
Part of the initial assessment is the assessment of do they have those kinds of needs for durable medical equipment, and if not, making sure that it's there at the beginning of their services so we can get that stuff done very quickly. That's one of the things about hospice programs and doing these things. They're nimble, and we can work very quickly to address those needs that otherwise might be kind of daunting to try to do it yourself or an outside physician doing it on their own.
So hospice isn't just moving into the hospice house, but those services are most commonly, I suppose, start at home, and then someone at some point, the team, including the family, would decide that level of care is raised to where they need to move into the hospice house. And so what does it look like at the hospice house?
Well, in the vast majority of people that are seen, their care is delivered and managed at home, and when they want to die at home and that's their preference, that's what happens with the vast majority of people that come to hospice care. We have the benefit of having the two hospice houses in our organization, so if someone does get to a point where their care exceeds the family's ability to do that, whether that's the sophistication of the care or whether it's just the exhaustion that goes on with some of the care, then they can elect, if that's what they want to do, to come to the hospice house for their last weeks of life. So if that was the case, then they could be transferred in. Then that's a different scenario. Instead of hospice giving intermittent services coming into their own home, if they come into the hospice house, now our staff are doing the moment-to-moment bedside care of the patient with our nurses and our nurse aides, and then which is going to be supervised by hospice providers, myself and our nurse practitioners.
So I would picture that conversation about the place of care or where somebody chooses to die would be something that the social worker would be helping facilitate with family, because I can see a couple of ways where the patient may say, no, I'm leaving the house now because this is too hard on you, or the social worker sees how hard it is and helps that tough conversation happen.
Sure, and a lot of that's very fluid, and participating. Everyone in the team is participating in that, and so it may not look as defined as it's a social worker thing or a nurse thing, but they're doing it together as part of the team, and they're particularly adept at helping people sit down and have some of those difficult conversations. That's some of the unique skills that they bring to the team.
So counselor is a big piece of that, that nurse and social workers
Absolutely.
repertoire. You mentioned the taking care of emotional as well as spiritual needs. Is there, are all or are any of the hospices in this area specifically religious, or is that something that's, again, very patient focused?
Well, our hospice is non-denominational, but we have a cadre of chaplains, and I think one thing is it kind of gets to some of the myths of hospice care. There are people who think, well, a chaplain is going to try to convert me. It's going to be a religious thing. Yeah. And our chaplains are very good at understanding what are the spiritual needs of the patient, whether or not their spiritual history comes with a religious connection or a specific faith connection. So they're basically going to try to, if they're welcome and they come in, they're going to help them to answer for themselves what are their spiritual worries and concerns. So there's spirituality and there's religion, and they may be very different. Sometimes they're the same, but they can also be very different.
Mm-hmm. Okay, well chaplains, that word brings to mind the chaplains in the military who have to be very adept at that same kind of listening, lots of listening, and counseling. Well, we're very short on time here. Is there some final message about a myth that you'd like to bust about hospice care?
Well, the most important thing that we hear back from the survivors of patients who have had hospice services is they wish they would have done it sooner. And, we've talked a lot about this 6-month prognosis, and there's a lot of folks that I think, their view of hospice comes down to the final days of someone's life. And although we could be very important in helping them to be more comfortable, there's obviously a lot of other work that we can help people do in feeling supported and helping them with their total discomfort, not just their symptoms, their physical symptoms, but their emotional and their spiritual symptoms as well. So I think that that addresses what most people's reflection is I wish I would have involved hospice sooner. And I think that's a really key thing for people to think about.
I think that's a good thought to end on. I appreciate your coming, Dr. Bray.
You're very welcome. Thanks for asking me.
SpokaneTalksOnline.com. Cheers to better health, and thanks for listening.